I personally think that from the sound, the description, which you did very well actually, it sounds as though Xeloda on its own would be not enough. It would be temozolomide with Xeloda, or temozolomide, the one that Barbara mentioned, okay? And that, Barbara said that this is my first line treatment for chemotherapeutic agents now in this country. That's our MDT standard. It was difficult to get buy-in from the oncologist, but we force it, and it works really well. We've got very good responses. So, but look at this is Derek will give you a more accurate answer.
I think you did great describing the case, by the way, as well. It's obviously very complex. So, you know, to echo, we routinely now, based on recent data, in this situation would give Xeloda, which is a trade name. The drug is capecitabine. We give this with temozolomide, which is the other drug that Dermot's referring to. That's a drug name. Temozolomide, yeah. So Cap-Tem, correct. Tem is temozolomide, Cap is capecitabine, yeah. So that's the combination, and there's good data for this now. It's hard to get very good scientific evidence for data such as this because it's a rare disease, and you know, in other cancers like bowel cancer, you can have hundreds of patients in a clinical trial to prove it, but with a rare cancer like this, it's very hard to really prove this. So a lot of the data is based on smaller numbers of patients and so on. So even given that, you know, I would fully agree with Barbo and Dermot, temozolomide should certainly be added in here. So that's one option. The other option is if there's a sufficient time period between the lutetium historically and now, that's an option as well, to go back to that. So that's a second option. And of course, the best treatment for any neuroendocrine tumor is surgery. You know, even a limited type of surgery frequently can be of huge benefit, even if there's disease left behind. And that's controversial, but that should always be explored, and I'm sure, you know, the patient is linked in. That should always be looked at continuously. So I think augmenting the chemotherapy, the possibility of more lutetium, there is other drugs historically have been given, interferon and so on. You know, not knowing all the details of the case, you know, there's certainly many options.
I would like to comment too, and that first of all, I think it's interesting now to know what the Ki-67 is before you make any therapeutic decision. I mean, if Ki-67 is of around 20, then I strongly suggest to continue or add temozolomide. If it's less than 20%, you may consider another round of lutetium or PRRT, provided that the octoscan is positive again. So, yeah, I think these are the most important information that you need in order to proceed.
Can I ask you a question? You don't have to say where the patient's been treated, but is she been treated in a center of what we call excellence model?
She's in Venezuela.
She's in Venezuela.
And, so she's working with the local experts, but you wouldn't call it a center of excellence, no.
Oh.
And so that's why she traveled to...
There is a South American group now involved in neuroendocrine tumors, and we could give you the name of somebody that perhaps the Venezuelan oncologist could contact in Brazil, in Sao Paulo. It's an email, and that might be helpful in terms of communicating from a language point of view. Okay, and the doctor's name is Frederico Costa. I'll give it to you later. Okay, and that might just be a simple email just to switch the oncologist on, if you like, something like that.
Another thing I forgot to say regarding your sister, in all young patients with pancreatic neuroendocrine tumors, we also try to exclude the presence of MEN1, a hereditary disease, and that is easy. You measure calcium and prolactin. That should always be done in young patients.